Thank you very much. I would like to thank you for this honorable invitation. Venous thromboembolism, deep vein thrombosis, and pulmonary embolism is a common acute multifactorial disease with a 5 years cumulative incidence of recurrence of 25%, increasing exponentially with age. VT is a chronic disease with high rates of morbidity, mortality, and recurrence associated with high costs. It is as common as stroke. Thrombophilia, which comprises congenital and acquired hypercoagulable states that increase the risk of first and recurrent venous, and in some cases, arterial thromboembolism is among these risks. Thrombophilia is a typical multifactorial disease. In inherited thrombophilia, gene-gene and gene-environment interactions play a vital role. Coexistence of different prothrombotic defects increases the risk of developing VT, either in the presence or the absence of transient acquired risk factors. This means that inherited thrombophilia, differently from hemophilia, does not follow the single gene defect model. The pathogenesis of VT involves both genetic and environmental risk factors. The multifactorial and polygenic nature of VT, in which inherit strongly modulate the onset and progression of VT. Actually, of VT. Appropriate primary prophylaxis, treatment of acute events, and secondary prophylaxis of recurrences should all result in a marked reduction in morbidity and mortality. However, the benefit of antithrombotic prophylaxis or therapy must be weighed against the risk of bleeding and other adverse events of antithrombotic medications. This requires stratification based on individual transient and permanent risk factors. Pathophysiology mechanisms leading to thrombosis are traditionally explained by the Virchow's triad: disruption of normal blood components and venous function due to a complex interplay of stasis, vascular wall injury, and hypercoagulability. We can see the role of thrombophilia in this triangle in the hypercoagulable state. Whether an episode of VT was unprovoked or provoked by an environmental risk factor, and if provoked, whether the factor was transient or persistent, has important prognostic and treatment implications. Scores from thrombophilia conditions and other genetic and non-genetic risk factors permit estimation of risk for first and recurrent VT. Therapeutic strategies can be derived from this risk stratification. We see which comes from reduced levels of natural anticoagulants, such as antithrombin, protein C and S deficiencies, or increased levels of procoagulants, and these include factor V latent and prothrombin mutation. This is a table with the traditional classical risk factors as we know them. Nowadays, this has changed. So, nowadays, we talk about a major transient risk factor, and patients in this group have very low risk of recurrence after stopping anticoagulation. It is estimated to be approximately 1% per patient year and 3% recurrence risk at 5 years. Examples are surgery with general anesthesia, lasting over 30 minutes, major trauma or fracture, prolonged immobility, cesarean section, heat and COVID infection for hospitalized patients. Is characterized by a 3 to 10-fold increase in the risk of having a first VT episode, and these patients have a 15% recurrence risk at 5 years. Examples are surgery with general anesthesia lasting less than 30 minutes, confined to bed for less than 3 days, estrogen therapy, included gender affirmation hormone and surgery therapies, pregnancy, COVID infection for non-hospitalized patients, minor trauma or fracture, and brief immobility. Major persistent provoking factors are active cancer. It is known that there is an increased likelihood of cancer diagnosis in patients with unprovoked VT. High risk of recurrence after stopping anticoagulation, estimated about 15% per year. And antiphospholipid syndrome is in this category. Minor, persistent, ongoing, non-malignant conditions are inflammatory bowel disease, obesity, personal or family history of VT, and pacemaker placement. And what is an unprovoked VT? An episode where no provoking risk factor can be found. This is characterized by an intermediate risk of recurrence after discontinuation, and it is estimated at 10% at the first year, 16 at 2 years, 25 at 5 years, and 36 at 10 years. We prefer the term unprovoked over idiopathic to describe these patients. The word idiopathic suggests that there is no reason for thrombosis. However, whether or not there was an environmental factor, patients may have non-environmental risk factors, such as hereditary thrombophilia, older age, or male sex, which do not qualify the event as provoked, but may influence the risk of recurrence. Despite using standardized criteria, some patients will be difficult to categorize as having either provoked or unprovoked episode. So the distinction between these is not always a black and white. Again, we see here that the unprovoked episodes are in the middle with an intermediate risk of recurrence. Patients at any point from left to right may or may not also have other factors, intrinsic, non-environmental, such as hereditary thrombophilia, male sex, or advanced age. When is provoking factor considered transient? It may be difficult to decide if it is transient, persistent, or combination of both. However, VT may be provoked by a transient factor in patients who have persistent risk factors. There can be an overlapping and or existence of multiple risks within the same individual. Some patients have serious comorbidities, whereas others do not. If a patient has a persistent condition that is an important risk factor for recurrency, the episode is considered to be associated with a persistent provoking factor. Strong provoking risk factors include major surgery and active cancer, but most events are unprovoked. Cancer is the most important persistent provoking factor because of its high incidence and strong association with recurrent thrombosis. So 20% of events are cancer associated, 20 to 30 have transient risk factors, and the remaining 40 to 50% are all unprovoked. Here we can see the established mutations of inherited thrombophilia, which includes the natural anticoagulants, antithrombin, protein CKS, which are rarely found in the general population. They account for no more than 10% in individuals with VTE. And here we can see the risk for a first VT episode, factor V laden, which is the most common, and we can find it up to 10% in the population of the Western world, and it can be found up to 20% in individuals with VT, and it increases to 5-fold the risk for the first VT episode. This is an interesting a table. You see that it comes from a journal which is was published in April 2023, with all the acquired environmental, genetic, and mixes risk factors for initial episode of VTE. I find here interesting that minor, acquired, persistent risk factors are renal insufficiency, arterial hypertension, congestive heart failure, diabetes, polycystic ovary syndrome, hyper and hypothyroidism, myeloproliferative neoplasms, and paroxysmal nocturnal hemoglobinuria. From the genetic factors, major with a more than 10-fold increase in the risk are characterized the homozygous factor V-laden patients or the homozygous prothrombin mutation and the double hit, as we call them. That means that they are heterozygous both for factor V-laden and prothrombin mutation. And in the moderate, genetic factors are the most common heterozygous factor V-laden or heterozygous prothrombin mutation. In this table, we can see risk factors for recurrency in unprovoked VT after stopping anticoagulants. The risk, as we see here, the risk is higher in patients with minor transient factors than with major. Here is the role of hereditary thrombophilia again, giving a risk ratio 1.2 to 2. VT recurrence risk assessment can be challenging because of risk variability among patients with unprovoked VT. Current guidelines for VT treatment and prophylaxis are based on risk scores. Several models for recurrence risk quantification in patients with unprovoked VT exist. One is here we can see all the prediction models. From them, the HER2 and Vienna scores have good to excellent predictive accuracy in identifying patients at low risk for recurrence. However, these tools have methodological limitations and modest predictive performance in external validation studies. Recent guidelines emphasize individualized VT risk assessment. In the web, you can find these scores. For example, the HER2 score, which can identify female patients at low risk for recurrence after a first unprovoked VT in whom anticoagulants can be safely discontinued after the 3 months. One or more thrombophilic factors are identified in 50% of all patients with unprovoked VT. But who of the patients is considered for a specific thrombophilia testing? Those patients with a history of recurrent VT or with an episode first occurring before the age of 50, unprovoked VT at any age, VT at unusual sites such as Plachnik veins, cerebral veins, Budd-Chiari syndrome, VT patients with a positive family history for VT, or VT secondary to pregnancy, or combination of arterial and venous thrombosis for antiphospholipid syndrome. If we perform this specific thrombophilia testing, this will help us identify patients likely to have an underlying thrombophilia. Risk of first VT event is elevated in patients with thrombophilia, but data on whether thrombophilia elevates VT recurrence risk is less clear. So thrombophilia testing is performed routinely, despite recommendations that it should be performed only in patients in whom results may have management implications. In these triangles, we can see the evolution of inherited thrombophilia testing over time. So in the previous years, we used to test many patients, but nowadays the triangle has come up, down, and now we are here. Thrombophilia testing can be offered in appropriately selected patients with unprovoked VT if results will impact anticoagulant choices. knowledge of underlying thrombophilia may influence decisions regarding hormonal therapy and oral contraception in females. However, unselected thrombophilia testing is associated with high healthcare costs and patient anxiety. Again, in this table, we will focus in the indications for thrombophilia testing. We see, again, unprovoked episodes in unusual sites, with recurrent episodes, or provoked with minor risk factors. Initial thrombophilia evaluation includes factor V latent prothrombin mutation. You see that antiphospholipid antibodies are here included because if we find them positive, for example, in a patient with a triple positive antiphospholipid syndrome, then we will not use DOACs, but low molecular weight bridged with vitamin kappa inhibitors. And secondary evaluation involves the natural anticoagulants deficiencies. Traditional inherited thrombophilia are all associated with genes of the coagulation and the anticoagulation system. However, a meta-analysis of genome-wide association studies identified several genes associated with inflammation, red blood cells, platelets, and they are also associated with the VT risk. The researchers that performed genomic and transcriptomic association studies and identified 16 novel susceptibility loci for VT say we identified new genetic loci contributing to the risk of VT, some of which are outside non-coagulation pathways, and this is very important. Which patients are we going to test for occult malignancy after an episode of unprovoked VT? Unselected extensive evaluation in patients without symptoms, signs, or laboratory abnormalities suggestive of cancer is not associated with improved survival. This approach leads to increased healthcare costs and patient morbidity, including anxiety. However, patients who have clinical findings suspicious of malignancy must be examined with cancer evaluation-based standard methods according to their clinical presentation. For example, to perform endoscopy of the upper and lower gastrointestinal system if the patient has anemia, etc. There are some uncertain thrombophilic conditions, such as hyperhomocystinemia. So the MTHFR gene polymorphisms are associated with elevated homocysteine levels, but have no clear association with the VTE risk. Impaired fibrinolysis, high levels of lipoprotein A, and while high levels are undoubtedly an independent risk factor for coronary artery disease and other atherosclerotic processes, data on the association of high lipoprotein A levels with VT are inconsistent. Other factors are protein Z deficiency and the sticky platelet syndrome. How we treat these patients? The days of managing all VT patients in a uniform manner have come and gone. So more recent guidelines emphasize in personalized care as no one size fits all. So after 3 to 6 months of anticoagulation, we assess the bleeding risk. And if there is high bleeding risk or the episode was provoked by a major transient risk factor, or in women with low HER2 score, we stop anticoagulation. In all other cases, we continue for an extended, we give extended anticoagulation or indefinitely. In this category, we have men with unprovoked episodes, women with high HER2 score, patients with thrombophilia, recurrent unprovoked VT, and patients with active malignancy. Extended anticoagulation decreases the VT risk by 80 to 90%, but it is associated with increased bleeding complications too. Aspirin has some efficacy in mitigating VTE recurrence, but is inferior to therapeutic anticoagulation, about 30% versus 80 to 90 risk reduction. We must have in mind that there is an important role of low-dose DOACs in extended anticoagulation. So low-dose DOACs decrease VTE recurrence with bleeding risks comparable to aspirin, so having a favorable net clinical benefit. So we must remember that at 3 months, we will reassess the patient, discuss with the patient, assess again the bleeding risk, and discuss the long-term anticoagulation plan. Consensus guidelines suggest that anticoagulation should be continued indefinitely in patients with unprovoked VTE who do not have a high bleeding risk. So this gives the green light to extended anticoagulation. There are guideline recommendations for the management of unprovoked VTE in specific clinical scenarios, but we will not say nothing more about this. And at the end, there is another interesting group of patients. They are transgender with a VTE, and these patients face particular challenges. Hormone therapy is a key component for transition from male to female. Cis women with hormone-associated VTE who continued oral contraception after stopping anticoagulation had a 4-fold increased risk of recurrence. Although the risk for transgender women with hormone-provoked VTE is not known, similar recurrence risks may probably apply. However, discontinuation of hormones in this group of people is often unacceptable. It is considered extended anticoagulation if continued hormone therapy is chosen by the patient for quality of life reasons. So VTE is induced by a complicated interplay of acquired, environmental, and genetic risks, among them thrombophilic conditions. A clinically significant VTE risk rarely consists of a single thrombophilic condition. Usually one or several thrombophilic conditions together with other risk factors add to the total risk that determines the type and duration of primary-secondary prophylaxis of first or recurrent VTE. Patients with unprovoked VTE comprise an heterogeneous group with significant dangers requiring further investigation. Patients with unprovoked VTE are at a significant increased risk of recurrence, but testing for inherited thrombophilia has not been shown to alter this risk in a way that might guide decisions about duration of anticoagulation. We should be proud of the progress that has been made, accept the remaining unexplained heritability, and with our understanding of pathogenesis, try to discover novel, safe, and effective therapeutic targets. In the future, additional biomarkers for predicting VTE, safer medications, and machine learning algorithms will revolutionize prediction and prevention of this common disorder. Thank you for your attention.